before I went over there, I was happy, go lucky, laughing and everything like that. When I came home, even to this day, I was smiling. I didn't talk about it. And I thought that I would spare people, because, you know, Vietnam is not a nice place. When I came home, I knew that I started drinking more, and also that I couldn't really hold on to a job. I couldn't have a successful relationship with a person. I would maybe be with them for about a year or something like that, and break up, break up. And my job, I couldn't have anyone like bossing me around. And I did go to restaurants. I had to have my back against the wall looking, so I'll be able to look at everything. I just keep thinking that somebody had acted. And I figured there was something wrong. I had a short temper. I kept yelling for, you know, no good reason. And so I went to the VA, and what they did is they said, well, do you have PTSD? And I said, no, I don't even know what PTSD is, so I don't know. And they get you familiar with what PTSD really is, and how it's going to affect you, and why it affects you. And it was pretty nice to know that there's a reason for what I was doing. So I would definitely recommend any veteran go try to get help. It is very much better knowing the reasons why you're like you are, and also to be able to work things out.
So what stands out from that video for you?
Working.
Nothing? What can you learn from listening to how he talks about his experiences? Make you talk. You're going to talk to me. That's not really you.
I think just saying that, like, understanding and knowing what his problem is, so that way he is able to treat it and maybe find things that won't trigger his PTSD and keep him more calm in the situation.
Yeah, so I mean, here's a guy who is a combat veteran, and granted, in Vietnam, we didn't know probably as much about PTSD, or definitely didn't talk as much about it as the military does now. But here's a guy who doesn't even know. They said, do you have PTSD? He's like, I don't know what that is. Right? Doesn't even know what PTSD is. He just knows that, you know, he feels a certain way that other people don't feel, and that something wasn't normal about that, and he needed to seek some help for that. Right? I think now it's much more. We're much more aware of that, and there's much more openness to talk about it. But still, with when dealing with military people that are in the military, there is still sort of a stigma of PTSD in the military, and the sense that you're weak if you get PTSD, and that you should be able to cope and deal with it. When he talked about his self-medicating, and that's a big thing that happens often with people, particularly in the military, with PTSD, that sort of thing.
The days when I was going through what I call my Chernobyl period, I slept 1 or 2 hours every other day, and I never slept without a loaded gun and a survival knife near me. I also had a 140-pound Rottweiler who wouldn't have allowed anything to happen with me, and I trained him as well as any military dog.
So one of the reasons I'm showing this clip is because of the issues with sleep, and we'll talk about that with the research.
But I still felt vulnerable. I still felt I was the only one on guard, and my adrenaline would get so high just thinking about being there and the only person armed that I slept very little. That didn't last for long because nobody can go 2 days with an hour or 2 of sleep, and that just made me worse. I found out how to take naps. I found out how to, I slept in a chair rather than a bed because that made me feel less vulnerable. I slept in clothing rather than undressing because then I was ready. I never felt like there were Viet Cong in the tree line because intellectually, because I knew I was home, and that was a safe place. But in my spirit, in my anxiety, felt like I was always under a sniper's scope. And my adrenaline rush was so high, I could go for a long period of time without sleeping. But that didn't do me any good at all. I had to learn sleeping. I was off at sleeping classes, I was off at meditation, relaxation, I was off at a lot of things. Some things I did, some things I didn't. But certainly everything I did helped in one way or another.
So, again, one of the reasons I was showing this video is because of the issues that often happen with sleep. But one of the things that's similar between the woman that we saw in the first clip and him is this idea that you have these feelings, right, that occur from the PTSD, and you know that there's not a reason to be having these feelings, but there's nothing you can do to stop them from occurring until you learn some of these relaxation techniques, meditation techniques, cognitive behavioral, reinterpreting your thoughts, until you seek some help and get some actual treatment in order to control those, or manage, maybe not control, but manage those feelings better, right? One of the things we'll talk about when we get in the research paper is sleep is really important just for normal life, right? Just for people that don't have trauma or don't have mental health issues. And when you compromise sleep, even in a normal individual, it produces cognitive deficits, it produces issues. And if on top of that you have mental health issues, it really exacerbates those. And so stress and sleep are two of the biggest things that are under people's control that they can use as an advantage to helping control some of these issues. Let's see what the next one is.
Situation was that we were on a mission. We were heading north. The truck in front of us hit a roadside bomb. There were no survivors. I had injured my back, my head, and my arm. The passenger that was sitting in the seat where I was supposed to have been sitting had injured his entire right side. That's something I've carried with me, and I'll always carry with me. I was diagnosed with PTSD when I came back in October of 2004. I started having nightmares. They had to put me on sleeping pill for that. They had to put me on anxiety medication for it because I was having panic attacks daily before. Found out the sleeping pill wasn't working. I started having breakthrough dreams. I didn't want to work. I didn't want to leave my house. I didn't want to do anything. I was getting in trouble at work. One day I guess you could say I went off and I cussed out my NCO, my platoon leader. And he was going to write me up. And my first sergeant stepped in and said, no, she's going to go see the psychiatrist. I found a counselor that said, okay, you can't do this anymore. You've got to face what's really going on. And now I've got a great support team. I am doing better, and that is due to the warm therapy that I get. It is due to the VA doctors here that I see in DC. I owe a tremendous thanks to the counselor that I've got. Everybody should take the chance and seek out their VA system. I think that's one of the most important things. I can't stress it enough.
All right, so again, one of the reasons I showed this clip is it's a more modern clip. So the other two were Vietnam veterans. This is a veteran of the Gulf Wars again, having sleep disturbances. But one of the things that I think is important about this clip is that she was prescribed medications for this, but no therapy. And while that might help initially, often when we're on pharmaceutical drugs for long periods of time, our body tends to start compensating for that, and the effects start to wear off. And it was really, again, the cognitive behavioral therapy, the working with the therapist to learn how to manage, right, these feelings, that is what's most successful sort of treatment for individuals. How are we doing on time? All right. I think this will be the last one. This one's a little bit longer. Again, this is a more modern clip. Some of the things to pay attention to is the role that stigma plays and how this individual sort of reports why he didn't really want to seek treatment.
I'm always worried about somebody coming in my house and hurting my family. But I'm always on guard, and I'm ready for anything at any time. I used to be able to determine combat zone and home, but now to me, everything's combat zone. It's a pretty ugly thing. You always think someone's out to get you. You're 2 steps ahead of them. You're ready and just waiting. That's because of the PTSD. Somebody got taken in the morning. PTSD is no joke. And if you got it, you'll understand exactly what I'm saying. I joined the Army in May of '96. I've been in 16 years come May, and I've been on 4 deployments. Well, the camp that I was at is called Combat Outpost Atomic Miracle. We were down in Gunhall Valley, surrounded by mountains, and over to the left-hand side of us where I was, my motorpool was at, was Pakistan. Every day was a fight for survival. You just didn't know when it was coming, but you knew it was coming. 1st of May, I got a briefing around 11:30 on what was going to happen the following morning. I came back, briefed my soldiers, prepared for battle. Our main objective was to man the front gate. Anybody come through that front gate, they were dead. All of a sudden, we hear one whistle. First round landed on the left-hand side of us, and knocks me and all my guys on our backs. We jump up. The second round came in, hit one of the fuel tanks on the 22-ton crane, instantly just blew it up, caught the motor pull on fire. The last mortar round, an RPG recoilless round, landed 6 to 8 feet in front of me and my guys. It blew me down first, and then 5 to 6 of my guys got hurt, and 2 of them seriously wounded, and one of them being me and PSY333. He almost died.
So when I heard about my husband, I was in shock and I started crying and I ran out of the room. At that point, I had no idea how bad it was or wasn't. I just knew he got, I think it was his 2nd surgery at the time. I was a wreck for a while.
My injuries, I got wounded in the penis and my right thigh. I took, can't give you an exact number of shrapnel. I had a hole the size of my fist in my right thigh, and my penis was split right down the middle of her stomach and to the rim of the head. You know, that's my man who, when I first came to in the infirmary out in Cobb Hunter in Pest Valley, where I was up there with gun dogs, Delta Company. I just couldn't believe it. I went hysterical, just in shock. And me and my wife were always thinking about having a 3rd kid, so that's a no-go, it's over. My whole world was flipped upside down. They'd done a total 360. Felt like I was useless. I had no job, I had no soldiers. I couldn't function, couldn't think on my own, I couldn't walk on my own. I had to have help in and out of the bathtub, on and off the toilet. One of the hard things I've ever had to go through. I think about my wife and kids. kids. If it wasn't for my wife and kids, I can probably guarantee you I wouldn't be here. My wife put up with a lot. I put her through hell, and she's still here with me. It shows how strong of a woman she is.
Well, we've been together almost 8 years. I love him, and they say through sickness and health, it's from night to day the way he was before he left. It was to the point where I was crying every day because I didn't know how much longer I could take it anymore. I remember there was one night where I woke up and he wasn't there, and I'm looking in the house and I have no idea where he is. And he's outside in the front yard all the way down the street. I guess they call him Level Black, which is like the very worst.
There's a lot of things that come along with severe PTSD. Sleepwalking, can't sleep for days at a time. When you do sleep, you only sleep for an hour or two, and you're right back up for 3 or 4 days. Hallucinations, constantly thinking about the situation what was at hand that put you in the situation you are in now. Thinking about seeing the faces of the soldiers that either passed on or got hurt severely. That's an everyday struggle for me.
He asked me on a scale of 1 to 10, where do you think I am? Do I need treatment? Am I really that bad? And I told him truthfully and honestly, I said, you're probably at like an 11 or 12. You really need to go. It's really that bad.
That's our cabin, San Antonio, Texas. Been in 16 years. Me and my guys got hit with 4 mortars and I'm going as far as we can around. Left pieces of scrap on the speed section. 5 sticks to the ball, do the same goal. Mother goes to the now. That's super enough.
That was a really big help to be around other vets and soldiers that have been into similar circumstances like getting wounded or getting blown up and getting hurt real bad. We all could relate, and from the day that I walked in there until the day that I walked out and graduated, let me tell you something, that makes a really big difference for somebody just to understand that treatment. Being around those guys that have been through similar situations, it's one of the best things ever.
Gentlemen, hey, this happened.
I used to blame myself all the time for them soldiers getting hurt and almost coming to death. But I also got to realize I was the first one to get hit. And I also got to understand and tell myself that it wasn't my fault because I did everything I could to keep my soldiers safe, and I was the first one to get blown down. So that's another part that keeps me going. I think that helps me move along sometimes.
So you remember what that's pretty cool.
My squad leader, platoon sergeant, commander, first sergeant, all them guys and the medical staff really taking good care of me, went above and beyond on my behalf, and I just want to say thank you because I couldn't ask for no better leadership or chain of command.
All right, so what are some things that you can take away from that case study?
How critical a support group could be
Yeah.
in suffering from PTSD.
So you see an example there of group therapy and how group therapy can be very beneficial to know that you're not alone, that there's other people struggling with this. To learn from people that are successfully dealing with it, but also then to be a mentor to people that are new and coming in and are struggling to find their way and how to deal with it, right? What else?
A lot of his PTSD came from worrying about how he could protect his soldiers from him.
Right, and so when people are in leadership positions in the military, right, they have a whole other level of trauma that can be associated with this. It's not just what happened to me, but they feel at some level responsible for the injuries and the things that happened to other people, even though they know that there was nothing they could have done, that they were doing the best that they could, that it wasn't their responsibility. There's still that survivor guilt, that that sort of secondary level of trauma that can happen. Right? Did you notice how many medications he had? That's a lot of medications, right? So sometimes people can be over-medicated in these situations, and again, what we've found time and time again is that medication can help reduce symptoms to get you cognitively in a place that you can benefit from therapy, but in the long term, it's really therapy. It's really learning a cognitive toolkit, if you will, that is the most successful thing, right, in terms of these treatments. All right, let's switch gears and talk about these research papers. All right, so the first one, excess glucocorticoids in the hippocampus. Why did they do this study? What was the background information?
They already knew from a few other studies about like the neurotoxic phenomenon of high glucocorticoids, and they did a study on adult guinea pigs in their hippocampus. And so they were really trying to demonstrate like what was going on with the hippocampal neurons with their neuromorphology and the scenario, to see if that was also another factor that was aided in memory deficits.
Yeah, so previous studies found decreases in the total number of hippocampal neurons. And this study particularly wanted to look at the morphology. What does that mean?
Axons and dendrites.
Yeah, the connectivity, right? What's going on at a more intricate level than just neurons are missing or neurons are disorganized, right? They focused on the CA3 hippocampal neurons. Why did they focus on those? So tell me about the importance of those. So the hippocampus is a very complex structure and has specific connections between different parts in order for it to function correctly, right? So you can tell me what the CA3 neurons are, what the importance of them. Yeah, so why there's lots of different neurons. There are a whole bunch of different types of neurons in the hippocampus. Why did they focus in on this CA3 class? Is there anything important about those?
Because they're more vulnerable to the affect, and that's because of calcium regulation.
Yeah, so one of the reasons is that we'll talk about is their ability to regulate calcium, and why is that important?
Stress response. Doesn't calcium play a role in the stress response?
Yeah, apoptosis, right? So calcium dysregulation, destabilization or dysregulation of calcium, one of the leading causes of excitotoxicity, right? Of that apoptosis because we're too excited, right? And it turns out that the CA3 neurons actually have more internal connectivity than other neurons. And so they seem like a target that might be getting overstimulated. And then the fact that they are more susceptible to calcium dysregulation, right? So they play a role in encoding spatial memories and episodic memories. They play a role in sort of regulating the firing of other neurons in the hippocampus. And there's a specific pathway, the mossy fiber pathway, that is sort of plays a role in regulating the ability to encode memories. We know that this pathway is really critical for stimulating those neural networks and creating long-term memories. All right, so what were their methods? What did they do in this study? Cortisol?
Yes, sorry, I didn't remember this. For 21 days.
Yeah, so they got 10 milligrams of cortisol for 21 days. What does that do?
Increasing the stress response.
Yeah, right, so it's mimicking the stress response, right? So why are we looking at this about, PTSD? And PTSD at high stress levels, particularly following this. We saw these case studies where these people can't sleep, they're constantly under stress. High circulating cortisol. So we're doing that for 21 days, right? And then what are they looking at? What are their measures? Dependent variables.
You're looking at the length of some of the dendrites and the number of them.
Yes, right? So again, they're looking at the connectivity, they're examining the dendritic connections of these CA3 pyramidal neurons, and they're looking at the length and the branch points. So how long are the connections and how many synapses, or it's sort of how you can think about branch points. They're not actually looking at synapses, but where are these neurons? Who are they touching, right? And so pyramidal neurons are called pyramidal neurons because they look like a pyramid. So, pyramidal neurons have a cell body that's kind of like a pyramid, and they usually have one output that goes somewhere. It goes a long ways, usually, right? But they're getting input. So if we look at a pyramidal neuron and say, based on its structure, what's its job? Its job looks like get input from different places locally, and then make a decision about whether or not you're going to send your output to your target. Right? And we can break down the top and the bottom parts of the pyramidal neuron into what we call apical dendrites up here that are projecting into higher layers of cortex, and basal connections down here that are looking more laterally and locally at things. Why are those things important? Or are they important? Is the distinction between apical and basal important? All right, well, let's look at the results. All right. So here we see a control neuron, a sham-injected neuron, and a cortisol neuron on the right. And what did they find?
There were significant differences in the apical dendritic branch points, and the CA3 pyramidal cells had fewer branch points than the sham-injected ones.
Yeah, so they found a couple of things. One, they found that it was selected to these CA3 neurons. They didn't see it in the CA1 parenchymal cells, and they didn't see it in the granule cell dendrites, right? So two different types of cells that they don't see this effect of stress on. And within the CA3, there was no effect on the basal ones. It was really these apical projections, which are primarily the input coming into these pyramidal cells. Right? All right, so a decrease in apical dendrites, no effect on basal dendrites or on the output, on the axonal outputs. There was no effect on cell body size, and this was selected for these CA3 neurons. Right? So if we look at, again, in a rat or a hamster, this is the hippocampus here, right? And we see both GR and MR cells. And again, you can see that different areas, right? The granule cells are more down here. The CA1s are located in this area. The CA3 are down in this area. And you actually see maybe a higher density of MR cells, maybe not so much with GR, but MR receptors in that CA3 area. And so if we look at the structure of the hippocampus, again, there are this sort of intricate connections that are happening, right, between the granule cell layer and this mossy fiber pathway to the apical area of those CA3 cells that are kind of the primary output to stimulate memory formation or stimulate long-term memories, right? So why do they think this happened, right? They talk about the susceptibility that we mentioned earlier, right? And so it turns out that these CA3 neurons have an inability to sequester excess calcium. So often when so we have two ways to deal with calcium coming into a neuron. One is there are ATP energy regulated pumps that can pump calcium back out of the neuron. So calcium comes in a normal way to signal a release neurotransmitter, for instance, and then we can pump that calcium back out of the cell. There's also Golgi complex parts of the neuron that can absorb calcium in sort of almost like a storage unit inside the cell. And so when too much calcium comes in, it can absorb that and sort of hold the calcium so that it's not affecting the receptors and cellular mechanisms that calcium interacts with. And that is what these CA3 cells lack. They only have the pumps to get rid of the calcium. They don't have the ability to sort of capture excess calcium and prevent it from hurting the inside of the neuron. Right? Also, these granule cells that are projecting through that mossy fiber pathway to the CA3 have a high concentration of GR and MR receptors, and so when these animals are getting that daily injection of cortisol every day, those cells are becoming hyperactive and really over-stimulating and essentially damaging those apical inputs coming into those cells, right? That's why we think the apical part is more susceptible than the basal part because of the hyperactivity coming from those fibers. Good? Questions on this? Everybody understand how this could translate into problems of memory? What types of problems of memory would this translate into? are encoding new memories. Right? Encoding new memories. All right, so what do you know about slow wave sleep and REM sleep? What do you know about slow wave sleep? Who's taking Dr. Steinmetz's sleep class? Everybody? Nobody? That's such a good class.
Slow wave sleep is like low brain activity, and then REM sleep is like high brain activity.
Okay, good. It's a good start.
REM sleep is like, that's when you're like the deepest part of sleep, right?
Yeah.
Rapid eye movement.
Yes. All right. So slow wave sleep, we think, and a lot of this is still theory, right, is our restorative sleep. Things like growth hormones are released, our immune system becomes very active, sort of rebuilding antibodies and white blood cells. And it opens up, the brain opens up, and the interstitial areas actually become larger, and we think that drains metabolites and toxins and sort of a cleansing of the brain in slow wave sleep. We often, I think historically, we've talked about slow wave sleep being low brain activity and REM sleep being high brain activity. It turns out it's just different types of brain activity. So there actually is very important, it's almost like a ripple of like waves of brain activity that start in the front of the brain and sort of wash over towards the back of the brain, and it's rhythmic. And that's why we call it slow wave, because it's these waves, these slow waves, but the peaks of those waves are actually pretty intense brain activation. And what we think that that's doing is in declarative memories, it's sort of sorting through the previous day's memories, filtering out what memories are important and should be remembered, and what memories are probably not as important and can be sort of wiped clean. And then essentially we think it wipes the slate clean, so that when you wake up in the morning, you don't have interference of the previous day's memories and encoding new memories. What about REM sleep?
I remember from biopsych we learned about how it scrubs the emotion off of memories.
Yes.
So for PTSD, they can't because they're not getting that REM sleep.
Yes. So REM sleep does a whole bunch of stuff. REM sleep the brain activity looks like awake brain activity. It's not these ripples, it's sort of this random activity, and we now know that it actually looks like the things so it's not a mistake that slow wave sleep comes before REM sleep, and then we cycle in and out of these. And so what we think happens in REM sleep is the memories that slow wave sleep deemed important get consolidated in REM sleep. And the ones that slow wave sleep said, yeah, you don't need to remember that stuff, aren't being stimulated in REM sleep. So what's being stimulated in REM sleep is the important stuff. It also appears to remove emotion from memories. Right? And it also strengthens or resets the frontal lobe, that executive function area. Right? A lot of what we know about these differences is from selectively depriving animals or people of one or the other and seeing what effects it has the next day on their memories. All right, so again, in slow wave sleep, these areas open up, about 60% increase in space, better cerebrospinal fluid flow, and it looks like this is sort of a cleansing of the brain. In REM sleep, it's the only time that we have essentially no norepinephrine, which is important in these other papers that we read about, right? No norepinephrine during REM sleep. So what we think happens is emotional memories are being replayed in REM sleep, but in absence of the vigilant signal. Right? And when we talk about dreams, dreams are when we consciously, even though we might be asleep, but our frontal lobes are conscious of this awake-like brain activity and tries to interpret it, right? Which sometimes we interpret that in really weird ways, which is why dreams can have really weird storylines to them, right? if there's high levels of norepinephrine, so we're not in a safe neurochemical environment, then those dreams often contain emotion because of the presence of norepinephrine and become nightmares, right? And that's when sort of the difference we think between nightmares and non-nightmare dreams, right? Is whether or not emotions being triggered during that dream. And so the brain is trying to scrub emotion off during REM sleep, but if there's an inappropriate amount of norepinephrine present, it's actually reinforcing those emotional memories instead of scrubbing the emotion off of them. Right? All right, and there's research, I'm not going to get into this because we don't really have time to do it, but there's research that shows if I show you a bunch of emotional issues and let you sleep, and then show you them again, you rate those as less emotional, presumably because the period of sleep helps scrub some of that emotional edge off. Then if I show them to you and wait the same amount of time while you're awake and show them again, you don't have that reduction in emotion. And there's a change in areas like the amygdala and the frontal lobe, where with sleep, the amygdala is less active. When you're awake, it's more active. Again, what does the amygdala do? Emotional value to things, right? So sleep actually helps us reduce that activity. And frontal lobe gets stronger, and frontal lobe helps sort of govern and suppress activity in the brain. All right, so sleep and PTSD. What we don't know, we know that trauma causes sleep disturbances. Right? One of the things we don't really know is, we talked about the susceptibility. Why do some individuals develop PTSD and others don't? We talked about the number of receptors that they might have for cortisol could be an influence. Whether or not they have pre-existing sleep disturbances could also be a predictive factor, right? If they're not as good at scrubbing off emotion from memories, that might make them more susceptible to PTSD forming. What we do know is after trauma, there definitely are sleep disturbances that make it difficult for that to happen, and we think that's because because there's too much norepinephrine, too much arousal present, we're not able to suppress that norepinephrine effectively. Right? So here we see a soldier before deployment, and then there's sleep patterns after deployment. This is a soldier with PTSD, and you can see that there's not as much restorative sleep, a lot more REM sleep periods here. And the REM sleep is disorganized. It's not located mostly in large blocks back in the second half of our sleep period. All right, so in the review article, they talked about lots of different things that are associated with this. Insomnia, nightmares, sleep apnea, movement disorders. So essentially not having the appropriate REM sleep. Right, having disrupted REM sleep. Right? And we know that there's comorbidity of PTSD and sleep disturbance with other psychiatric disorders like depression and suicidal ideation as well. All right, so what are some ways they talked about treating sleep disorders?
Processing treated the sleep symptoms better than anything else they found, and that's what they ended up recommending as a treatment, since most treatments help with daily PTSD symptoms, but not the main ones.
All right, so in our last couple of minutes, what does prazosin do? What is it? It's a drug, but what is its effects? What does that mean?
It means that it suppresses your adrenal system.
Yeah, so it's a norepinephrine antagonist. So alpha-1 is a norepinephrine receptor. So what we're doing effectively is saying is your brain can't make norepinephrine level 0 during REM sleep. Let's give you a drug that even though there's norepinephrine present, we're going to block its effects. So essentially you're at 0 even though norepinephrine is present. All right. Again, other things that are important that that review article talked about was psychotherapeutic interventions being very important in addition to some of these drug treatments. All right. We got to get out of here. We're out of time. But yes, essentially helping restore the thing that REM sleep is supposed to do was most effective in reducing nightmares and helping, again, treatment-resistant individuals is what we're talking about with PTSD. Get better. All right, thank you. If you can help me put the room back together, great.